Connected by purpose, driven by passion. This is Children's Healthcare Canada's Spark Live webinar series.
Children's Healthcare Canada would like to thank the following Keystone funding partners for their ongoing contributions that support all of our programs and activities. The Stollery Children's Hospital Foundation, BC Children's Hospital Foundation, the Children's Hospital at London Health Sciences Centre, the Alberta Children's Hospital Foundation, the Children's Hospital of Eastern Ontario, and Holland Bloorview Kids Rehabilitation Hospital. We would also like to thank the organizations that provide funding for our knowledge translation activities, which includes this Spark Live webinar series, the Spark Conversations blog, and the Knowledge Exchange Network. To learn more about Children's Healthcare Canada, you can go to our website, follow us on Twitter or Facebook, or you can sign up for our weekly Spark newsletter at childrenshealthcarecanada.ca/email, where you will learn about upcoming events, read the latest posts from our blog, and other exciting news and events from across the child and youth healthcare community.
Hello everyone, and welcome to another edition of Children's Healthcare Canada's Spark Live webinar series. I'm Paula Robeson, your host for the next hour. Spark Live is where we gather each week to curate, convene, and showcase excellence and innovation from across the child and youth healthcare community. And our goal is to spark conversation, ideas, and action. To ask questions of the presenters, please type your questions into the question box at any time. I will check for questions at the end of the session, but you need not wait until then to ask them. Just type in your questions as you think of them. We're delighted to welcome another Children's Healthcare Canada member, Alberta Health Services, as well as PolicyWise, to bring you applying principles of disaster psychosocial recovery to the COVID-19 response in healthcare settings and systems. For those of you on Twitter, please tag us at ChildHealthCan on any webinar-related tweet and share away. Now I would like to introduce our speakers. Naomi Parker is Project Director with PolicyWise for Children and Families. In this role, Naomi is responsible for developing and implementing the research and evaluation projects undertaken by PolicyWise. And prior to joining PolicyWise, Naomi also worked with the Alberta Health Services in the areas of addiction and mental health. Douglas Walker is the Chief Programs Director at Mercy Family Center in New Orleans, where he has worked for the past 22 years. In response to Hurricane Katrina, Dr. Walker created Project Fleur de Lis, New Orleans' largest school-based mental health program devoted to students struggling emotionally and academically in the years following the storm and destruction. Since then, he has expertise in responding to the mental health needs of large-scale natural and man-made disasters, including the Calgary floods of 2013 and Fort McMurray wildfire of 2016. Michelle Craig is the Executive Director of the Addiction and Mental Health Branch with Alberta Health, and she holds a master's degree in speech-language pathology. And Dr. Diane McNeil is Director of Promotion, Prevention, and Community Initiatives in the Provincial Addiction and Mental Health Portfolio for Alberta Health Services. It is my pleasure to pass the mic to Naomi.
Perfect. Thank you, Paula. Good morning, and thank you for joining us today. It is a privilege to present on this topic with my colleagues, Doug Walker, Michelle Craig, and Diane McNeil. As Paula mentioned, my name is Naomi Parker, and I work at PolicyWise for Children and Families. PolicyWise is a not-for-profit organization that seeks to inform, identify, and promote effective social policy and practice to improve the well-being of children, families, and communities. Simply put, PolicyWise seeks to promote better evidence for better decisions. Today, we will be presenting on the principles and core components of disaster-related psychosocial supports and how this body of evidence can be applied in healthcare systems and settings. All that will be presented today will be based on lessons learned from previous disasters locally, nationally, and internationally, as well as the experience and knowledge of those involved in the psychosocial responses and recovery. It is our hope that today provides you with an overview of the current evidence and base for a psychosocial response and how to apply this evidence in practice. Before we begin, we should have a common understanding of what we mean when we say psychosocial supports. Varying definitions of psychosocial supports do exist in literature, and the common denominator among these definitions is the integral interconnection between psychological, social, and cultural dimensions of human experience, whether this is at the individual, family, or community level. Several definitions further make reference to promoting well-being, while additional definitions include the fostering of resilience within individuals and communities. Every disaster has its own unique signature, and this is shaped by community capacity and relationships, the scope and type of disaster and location, and a contextual understanding is needed for any sort of response. Psychosocial well-being and the provision of supports must be an integral aspect of the overall disaster effort. Everything done in a disaster has the potential to impact the psychosocial well-being of individuals, families, and communities. And as such, these supports must be integrated into the overall disaster-related response, recovery efforts, planning, and preparedness. How the psychosocial response to a disaster is managed may actually be the defining factor in the ability of a community to recover. Such interventions require rapid, effective, and sustained mobilization of resources. Sustaining the social fabric of the community and facilitating recovery depends on the leadership's knowledge of a community's resilience and vulnerabilities, as well as the understanding of the distress, disorder, and health risk and behavioral responses to the event. A coordinated systems approach across the medical care system, public health system, and emergency response system is needed to meet the mental health care needs of a region. So within COVID-19, the experiences of individuals right now, as we all know we're living, include the fear of the unknown, infection, job loss, and death, fear for loved ones, a disruption to routine and normalcy, social isolation, and living in a prolonged state of stress. This results in an inability to focus, anxiety and panic, loneliness and depression, relationship and family conflict, and a disruption to the community connection and social fabric. The overall objective of psychosocial supports is to prevent pathology and promote psychosocial health and well-being among individuals who've experienced disaster. And there are a number of phases to this recovery process. It's important to note that not all individuals will move through these phases in the same way or at the same pace. And due to the variations between and among people who've experienced a disaster, there needs to be a knowledgeable and skilled team of individuals who can provide the support to individuals at large, at the level they are at, rather than where they are expected to be. And this should be done with the goal that as principles are put into practice, impacted individuals and communities will have the tools necessary to potentially reach a level of post-traumatic growth. As I've mentioned, every disaster has its own unique signature. And again, this is shaped by community capacity, relationships, the scope and type of disaster and location. As such, principles are absolutely needed to provide the parameters for a response that can then be framed by the local community context. There's a large body of evidence that exists related to disaster-related psychosocial supports. And the principles being presented today are informed by these bodies of evidence, as well as Alberta's own experience in recovery following recent fires and flooding. Collectively, all principles seek to prevent pathology, promote psychosocial health and well-being, and contribute to post-traumatic growth. I'm going to go through the principles individually, but it is important to note that communication is a foundation to all of these principles. The interchange of information, ideas, and knowledge by various mediums. All other principles rely on the use of communication to promote their objective and messaging to develop normal responses among those who have experienced disaster. Preserving human dignity is a significant concern in disaster recovery, including psychosocial supports. All three of these principles grouped in this section are based on social justice and emphasize the importance of respectfully meeting the needs of others through their full participation and decision-making. The principles of promoting a sense of safety and calming are interconnected concepts. They both acknowledge feelings of insecurity and the range of emotions individuals experience after a disaster. Feeling safe can lead to a calming effect, and likewise, being calm can make one feel safe. Identifying and building on assets implies full participation of individuals who have experienced the disaster. And through their participation, they can experience a sense of control over what will happen post-disaster, which can also lead to a community sense of efficacy. Viewing these three individual principles as a collective category strengthens them and highlights for others involved in disaster recovery that the notion of a community-led response and recovery to the aftermaths of disaster is a vital aspect that needs to be considered when developing and implementing psychosocial supports. An integrated support system refers to the idea that integration of support services within a wider context to serve as many people as possible. Providing multiple levels of psychosocial support according to need are required. And further, many groups of workers are responsible for addressing the disaster, and these individuals have training and care needs that need to be specifically addressed in ways that acknowledge the stress and trauma that they have experienced. This grouping of principles focuses on the intangible aspects that promote healing among individuals and communities. They are interrelated and complementary to one another and include well-established ideas in addition to emerging concepts found in recent literature. The three principles within this grouping focus on assisting individuals to identify, acknowledge, and move forward from an event that they have experienced. Most people may not specifically identify these aspects as important parts of their healing, but they may be involved in initiatives or activities that demonstrate these characteristics. Community-based initiatives that address these principles can be developed and implemented to assist individuals and the community to heal and move past a disaster. And the final principle, social fabric. Events such as disaster can tear the social fabric of a community and challenge the connections that already exist while altering a person's sense of place. This principle refers to the significance of social support and sustained attachments to loved ones and social groups in order to combat the stress and trauma and promote psychosocial health and well-being and increase access to information and supports, all the while creating a sense of security and connectedness. Collectively, those principles work to promote post-traumatic growth. And my colleagues are going to speak next about how to operationalize these principles. Before they do that, evidence has also identified necessary domains to implement and operationalize a psychosocial response. These include agreement among key stakeholder groups about the aims, values, and parameters for the design and delivery of psychosocial support. This agreement forms the basis for aligned efforts and is foundational to all other domains. The influence of leaders, various actions performed by their formal and informal leaders in order to sustain and achieve high quality, effective, and consistent psychosocial supports are necessary. Support processes, systems, and resources that are needed for organizations to function effectively and to provide high quality psychosocial supports. The existence of frontline staff, support staff, and supervisors who possess and apply extensive knowledge and skills related to psychosocial supports. This stable workforce is important for maintaining continuity. And finally, a system that embraces the processes and principles of ongoing learning and adaptation, while also including traditional approaches to monitoring performance, evaluation, and reported are necessary. It's my hope that in the next presentations from Doug, Diane, and Michelle, you will hear and see the application of these principles and these domains for a response in practice. Thank you for your time.
Thank you, Naomi. This is Doug Walker. I come to you this morning from just outside New Orleans, Louisiana, down here in the South in the U.S. A little bit more about myself. Yes, I have worked a couple natural and man-made disasters in Canada, but my experience here in the U.S. has really kept me, in some ways, more busy. And my trajectory here at Mercy has been over now going on nearly 23 years. For me, a seminal moment in my time was Hurricane Katrina. But after that, I went on to develop programming for our Deepwater Horizon oil spill. And then to be able to help our larger Mercy Health system later with what we
It looks like Doug is muted. Just give us 1 second.
Someone muted me again. All right, so I'll start again. So this is Doug. I work for Mercy, which is a large Catholic health system based in St. Louis, Missouri, with 47,000 employees. I've been with Mercy about 23 years, and so my experience with Mercy has been rich, sadly, with large-scale man-made and natural disasters. Hurricane Katrina was a pivotal point in my professional and personal life. I went on to develop programming beyond Project Fleur-de-Lis, which was mentioned, to address the impact of our Deepwater Horizon oil spill. And I've worked nationwide and worldwide in addressing large-scale man-made and natural disasters. So a lot of my work at Mercy now is consulting to our leadership around response, and particularly now the coronavirus. And I start my session this morning by quoting one of our Mercy coworkers early on in April as the coronavirus was setting upon our large system. Mercy extends across 4 states. So we are in Missouri, Oklahoma, Kansas, and Arkansas. And it's been an asynchronous experience because not all parts of our health system has experienced COVID-19 or the coronavirus in the same way or at the same time. So it's been a challenge in developing a response internally for our healthcare workers. And that's my focus today, acknowledging the fact that the normal is not easy now. For our coworkers across our health ministry, ER admissions are complicated and really mired by the threat of contracting COVID-19. As Naomi began and pointed out, that there are different signatures for each man-made and natural disaster. They're all unique, even down to place, person, time, and acknowledging that a wildfire in Fort Mac is going to be different than, say, Southern California based on what happened previously to that community. What the community is made up of. Is it First Nations? Is it additional special populations for consideration? What's the economics that are going on before the onset of the disaster? And to that end, we can acknowledge that with signatures come very, very sudden events. My experience with Mercy in responding to large-scale disasters was extended when I helped here, photo you see, respond to the Joplin EF5 tornado. That day, that Sunday afternoon, it killed, sadly, nearly 160 people. What you see here is the Mercy Hospital that was hit directly. And amazingly, no one at the hospital was killed. The parking lot you see here is trashed quite a bit, but know that the EF5 tornado was so strong that one of the ER doc's Chevy pickup trucks was found a half-mile away. And so these types of disasters, although there are different signatures, mandate that we look internally to healthcare workers, our frontline workers, to support them in what they do. Pandemics are not new to us. We've had a long history in our world in addressing epidemics and plagues. This is our most recent and unique, as Naomi began pointing out, is that pandemics are worldwide. They're a shared experience. That's good and bad. Unlike floods in Calgary, wildfires in Fort Mac, or Joplin tornadoes, there's no outside world to come in and help. There's no cavalry, coming to support. There is a worldwide experience of stress in everyone, where everyone is threatened and taxed. So that makes the coronavirus and the COVID-19 experience much more stressful, because there's nowhere to go for relief or to receive relief. The fear and uncertainty that comes with a coronavirus is akin to a radioactive event, like in Fukushima, Japan. You can't see the virus, which makes our anxiety even more rich in a negative way. Here in New Orleans, hurricane season now, we know when storms are coming our way. We can see it on the radar, and we can, for most of us, respond to it. Whereas coronavirus, we have to be vigilant every single day. There are 5 essential elements that were created after Hurricane Katrina during a think tank. And they align very closely with Naomi's essential elements, including safety, calming, this idea of connectedness, self and community efficacy and hope. So certainly safety and calming, as she pointed out, are directly connected. We want to always exude, especially in our communications to healthcare workers, that what we're doing to keep them safe, and always keep a tone of calm. Keeping people connected during Corona is probably the biggest challenge right now, that we're not connected physically anymore. It's more virtual. So that really takes away a lot of our human experience. Self and community efficacy is this idea that we can rebuild again, and that takes time. There's a timeline devoted to each disaster, and this one's going to be a longer one. We're certainly looking easily into 2021 until our lives are in some ways relieved of the coronavirus. And finally, hope, probably the most abstract of all the concepts, but we always want to look for signs of improvement in our lives and in others. This here is a slide from Mercy Leadership, our consulting team, looking at a response principles over time. I show this because of kind of our thought process in our stages and preparation, but also how off we were in responding as far as timeline. What we thought then and what we know now is quite different. So we're way past April, which you can see represented in here, some basic tenets around disaster mental health and very specific programming like psychological first aid, that kind of first minutes and hours, and then skills for psychological recovery, which is a long-term resilience program that was rolled out both in Calgary and up in Fort Mac and other parts of Alberta and Canada. And so we're expecting certainly this timeline to continue well beyond what you see here today, but we're also readjusting. I was saying before the call today that I'm meeting once again with our task force and looking specifically at our doctors. And I know we have physicians on the call today, but we're finding difficulty in finding ways to connect with our what we call hospitalists, so the physicians that are devoted to individual hospitals. Along that, we have to consider unique needs of nursing and other parts of our healthcare workers. And so being as specific as you can and being in tune with your healthcare workers' needs at multiple levels is important. Prior to the coronavirus, Mercy has and had in place levels of care for their coworkers, and I'm going to highlight them briefly right now. The first level is called How's Your Five, and you can look it up. We have a Twitter presence. It is a conversation. It was actually created out of the Joplin tornado by Mercy coworkers through focus groups. And I'll highlight it in a moment, but just know that How's Your Five is just a general conversation. How are you doing? How's your work? How's your relationships? How are you, what's your play like? What are your joyful activities? How are you sleeping? And how's your eating? How are your eating habits and consumption? Above that, so if How's Your Five is the general everyday conversation in the halls of our hospitals, I'll Listen is a stage up, which we created as part of our Zero Suicide programming. I sit on our Zero Suicide subcommittee. After helping create that a couple of years ago, we realized that we needed a higher level of campaigning around teaching individuals to sit shoulder to shoulder with folks who are really struggling. And that's happening a lot now for our healthcare workers, especially on the back shifts. So that 2:30 in the morning charge nurse who just has had enough. I'll Listen really does help, where people can sit down and be a good listener. We do have an embedded employee assistance program that offers additional support as well. And so in this way, we're offering to our coworkers a multi-tiered level of support. In addition, we do have pastoral care and what we call e-chaplaincy. So our chaplains are available 24/7 for any of our coworkers. Just a little bit about How's Your Five before I finish. The point here is not so much about the program, which we've rolled out across all of Mercy. Again, it's been implemented in parts of Canada and other parts of the US in schools. It's the message here is getting beyond I'm fine. And what I mean by that is I'm really asking all of you to leave this conversation today in not accepting I'm fine or I'm good from your coworkers. For those of you in the healthcare system right now, you are, yes, on the front lines, you're in the trenches, You can't accept "I'm fine" or response like "I'm fine" or "I'm good" from others, because that's not enough. You've got to connect with individuals. So ask them, how's the family? How are you sleeping? Are you eating? Are you getting enough time off? And so this way, we have to connect. And it is a challenge with coronavirus, but again, get beyond "I'm fine." That's my kind of big message for today. So finally, just to pull it all together, these are the 5 principles that I talked about. They align heavily with what Naomi has to talk about. And in a moment, I'm going to hand it over to other speakers, but know that I'll be available for questions. I want to thank you, and I'm going to toss it over to our next participant.
Hi there, my name is Michelle Craig, and my co-presenter today is Diane McNeil. So we're going to start with just a little bit of introduction. So as I said, I'm Michelle Craig. I work for Alberta Health. Alberta Health is the Ministry of Health, so we're part of the government, and we work extremely closely with the other half of us, which is Alberta Health Services. The two of us together are really what working together and collaboratively really makes any of the work that we do work, and certainly that's very true within the COVID response as well. So Diane, I'll turn it over to you to introduce yourself, and then we'll move on.
Thank you, Michelle, and good morning, everyone. Thank you for joining us. So I am part of addiction and mental health, the provincial team, and we are part of Alberta Health Services. And so, as Michelle mentioned, we are the health delivery system in Alberta. We're the operations on the ground. Back to you, Michelle.
Thank you, Diane. Okay, so we want to start by talking a little bit about the impact of COVID. We know that before the pandemic, about 1 in 5 Albertans, or that would be about 850,000 Albertans, experienced an addiction or mental health challenge in their lifetime. We know that that is going to be much, much higher through the course of the current pandemic. Indeed, every single one of us was affected in some way, and a lot of people who face other vulnerabilities or have other barriers to face will be impacted more. We know that people who either have COVID symptoms or themselves or in their family will be affected. We know that a lot of people are having adverse social or financial consequences as a result of the mitigation efforts that we've taken, such as self-isolation and our basic shutdown that happened for a number of weeks as well. And we know that everybody is experiencing some degree of increased anxiety. I heard somebody refer to it as latent anxiety, and I felt that was really appropriate. And that's due to just everything being new and different and trying to learn how to cope with new things. And I'm sure we're all experiencing that. So everybody is affected. Some people will be affected more. We know that we're seeing increased uptake in a number of our helpline type things. We saw that almost immediately when the pandemic started. And we anticipate that based on experience in other jurisdictions and what we're seeing in Alberta, is that about up to 50% of Albertans could experience moderate to severe anxiety, and 20% could experience moderate to severe depression. So we will continue to monitor this over time. I think the other thing to consider, as Doug alluded to, is this isn't just a one-time event. So the Fort McMurray fires, or the more recent Fort McMurray floods, which happened on top of the pandemic, or the Calgary floods, were sort of a one-time event. They were a fairly short period of time. Of course, this pandemic is lasting 18 months, 2 years potentially, and there could be more than one wave. So we really expect to see the impact of this playing out over a number of years, potentially 5 to 7 years after the end of a pandemic. So it is quite a long period of time that we need to be considering. And in that, we also know then that we need further investigation and monitoring to assess the change in impact on people over time, because our psychosocial needs of both those vulnerable populations and the population as a whole will evolve over time. So I'm going to turn it over to Diane.
So this graphic really introduces us to the emotional highs and lows that people might experience through the phases of a disaster, right from impact through to recovery. So in early stages, we might see those emotional highs. people feel heroic, they help each other. But as time goes on, I think some of those realities start to set in, and people start to feel perhaps disillusioned or experience setbacks, and then before they bounce back. I wanted to point out, though, that a good predictor of recovery is how healthy and resilient individuals, families, and communities are before an event. So any gaps or stressors, issues existing pre-disaster are usually exacerbated and spotlighted then by disaster events. So COVID-19 pandemic has created a big social footprint on almost every aspect of our society, increasing many of those pre-COVID issues while at the same time creating new ones, as Michelle alluded to. So this is why psychosocial support is needed in a recovery phase, to reiterate again, for at least 5 years after a disaster. So we've seen this graph play out for previous disasters in Alberta, and it appears it'll also hold true for the pandemic. The difference is, however, that a pandemic is not one discrete event. So next slide. So here are some examples of the key planning activities that are currently underway. Recovery planning for COVID has been a process of trying to get pre-existing services back into operation and also in a new way. It is acknowledging that everyone is impacted by COVID and will need some level of psychosocial support, but not everyone will require formal clinical supports. So we also know that there'll be new needs and trends emerging, and more people will be actively reaching out for support. So it's critical at this juncture that we don't pathologize people's distress and work with them to keep them functional and actively engaged in their disaster recovery process. So the key is to provide those adjunct services and support that aim to provide timely and meaningful interventions in what will most likely be an evolving and shifting environment. It's important to offer an array of those community-based supports and interventions that need to be nimble, flexible, and adjuncts, as I mentioned, to currently offered services and programs. In addition, being prepared to offer new recovery services or interventions. Michelle, did you have anything to add?
No, I don't. Thank you.
Okay, next slide.
So taking a look at this slide, this is really the graphic and structure that helped us to develop the response strategy that we have developed. There's also an investment plan, which I'll tell you more about, which has already been announced as well. So this is similar to what other people have mentioned. We've got the early phase, which was the information providing within Alberta, a really good example of information that everybody needed and was presented really well and really clearly was Dr. Dina Hinshaw's at one point daily and now a little less than daily updates. People became very attached and still are very attached to those announcements and listen to them every day. And that is an example of both that, how everybody was affected and the need for that kind of information. The timelines that we've got here are rough. So we've estimated phase 1, we're calling it March to June roughly, and these will shift. They're quite fluid as well. The next stage that we wanted to make sure that we responded to was the response phase. We said it's April to September roughly, we thought, and that's really looking at how do we offer more of those community and family supports. Again, it's a little bit smaller group of people. Not everybody's going to need these, but a lot of people will. Then again, moving up to the next level into the recovery phases between September and beyond. And we may already be in recovery, quite frankly, as we see an opening up of things and a loosening of restrictions, where there's a need for more focused support. And then for some people who are going to need treatment as a result of this. And we've seen certainly some of this play out in terms of some of those increased needs already. So as I mentioned, this graphic really formed sort of the basis for the response strategy that we are developing. So the response strategy that we are developing will be publicly posted. It's still in process. But a big piece of that is the investment strategy, which has already been announced and is implemented. I'll walk through fairly quickly. Again, this is very much laid out according to that graphic. So it starts in the phases. So we start with things that affect the whole population or support the whole population. There was an investment of 21.6 total million, and that is really about making sure people have the communication and phone and online supports. Ironically, we're trying to create connectedness through virtual things which actually take us apart. So it is certainly a challenge, as Doug pointed out, but that's certainly what we're trying to do by providing a lot more of that support. So some of the things that are happening and are in process, you have an idea of when we're targeting things, and there's been a bit of shift in these dates, but it's close. We have Together All, formerly known as the Big White Wall, which is an online support community. We have a number of online early intervention, low intensity therapy programs that are being started. We've expanded the Kids Help phone line and the crisis text line. And we're working to increase access to e-mental health treatment for professional support, which is specific to youth. In addition to that, we have some of the phone supports that are being expanded through the Addiction Mental Health Helpline, which has been expanded, and expanded 211 access to information, referral, and crisis support. So I'm going to give Diane just a moment to see if she wants to expand on any of these, because a number of these are actually being implemented, of course, by Alberta Health Services.
Michelle, I think you did a great job. I just wanted to add one that you haven't mentioned, and that is Text for Hope. So we do offer this. It's a free daily text messaging service that offers enrollees supportive text messages based on cognitive behavioral principles. And so we also have versions of Text for Hope for cancer care and also addiction support. So far, we have about 50,000 Albertans that have enrolled. And early evaluation results have indicated improved well-being, they're better able to manage COVID-related issues. They feel a greater connection to a support system, and that was mentioned by both Doug and Naomi. There's decreases in depression and anxiety and a greater ability to cope with loneliness and stress, and we know those are issues. It's funded by 6 of our hospital foundations and trusts in Alberta. Back to you, Michelle.
Thanks, Diane. These are some of the next 2 phases of work and investments that are happening. Talking about the need for promoting connection and community-led work and integration that Naomi referred to, as did Doug. And the community and family support phase here of 25 million is a community grant program. And I can tell you that this grant program is absolutely supporting all of those things. The first call for proposals is now closed and decisions have been made. The second call for proposals is for $10 million, and that is actually underway right now. And then there's a third call for proposals that will happen again in November for that total of the 25 million. So with the first $5 million call, which I mentioned is already closed, we had 61 new community grants established through that. So these are small community groups, people that have come together, identified a funder. We've got grants that are $5,000 and up, so which is why we were able to take $5 million and split it across 61 groups. We anticipate similar uptake on the second and third calls for the $10 million pieces. If people are interested in that, you can certainly go to the Government of Alberta website, and if you search COVID Mental Health Community Grant Program, the information will pop up. And as I said, there's lots of information there if you're interested in that program. But I think it's a really good example of community-led and promoting that coming together and that restructuring of the social fabric. And then finally, was 6.8 million was announced to support some very specific programming to increase addiction and mental health services available through primary care networks, and also to expand the Alberta Health Services family violence services, specifically with a focus on Indigenous, rural, and remote and suburban communities. Diane, is there anything you'd like to add there?
No, not this time. Thanks.
Great. With that, I will turn the next slide over to you.
So these are a few examples of the types of psychosocial training that my team has been working to adapt for Alberta since the 2013 Southern Alberta flood. So the objective of this training, which is PFA, Skills for Psychological Recovery and Wellness Exchange, and Doug had already nicely covered what those trainings encompass. So just to reiterate, though, the objective is to increase the psychosocial capacity of both Alberta Health Services and community agencies and services to support people in their ability to recover, both in their communities and the populations they serve. Now, the difference is, the big undertaking for COVID is we had to adapt this training to virtual facilitation and quickly get these up and running, which we did. Just a note on Wellness Exchange. It is, if you haven't heard of it, it is based on Skills for Psychological Recovery. It is a group facilitated curriculum and toolkit for professionals interested in teaching those skills to their communities. And so Wellness Exchange also can be done in non-disaster times. So that's the nuance there. So over a 3-month period since COVID, since we're able to adapt this training due to COVID, so from April till about July, we've provided so far 85 PFA virtual interactive workshops to about 2,000 Albertans free of charge. And so to our knowledge, there's no other jurisdiction providing this type of live interaction with instructors. And so our approach has been to train all types of service providers and communities, which with the intent to expand scope and reach that we talked about earlier. Next slide, please. So this is our last slide. Wanted just to mention another training piece that we're doing. It's called HeartMath. HeartMath is a stress management, emotional resilience approach. And it was a key intervention that we used in previous Alberta disasters and really has had strong uptake by professionals and the public. So we made this virtual as well, and we've focused our training on how HeartMath can support the well-being of service providers and how these skills can be incorporated into their practice. So with COVID, we've worked to offer condensed virtual 2-hour training for professionals, and we also offer a session via Zoom for the public. So from April till now, we've had 48 workshops with about 1,000 participants. And there's really been great uptake by healthcare workers. And I know each of us have talked about that already, how this is a particularly vulnerable group. So it is especially good to know that it is finding favor and good uptake in this group. So I think as a summary, what I'd like to say is really the right level and type of support needs to be offered. So keeping in mind that the best recovery outcomes and post-disaster occur when organizations work to support those natural supports and strengths and do not focus solely on the clinical support services. The main message is that everyone will need information, many will need community-based and family supports, and fewer, although importantly, some will need those specialized treatment services. And with that, we conclude. Next slide. Back to you, Paula, I think, for questions.
Yeah. Thank you so much. We welcome now questions. Just type them away in the question box. We've got a few that have come in already, but I encourage anyone else who has some last-minute questions to type away, and we'll get to them. So I'll take the questions in order now. So Sharon wrote that she's interested to know the impact, both individually and as a community, of compounded disasters. For example, a pandemic and murder or suicide of a colleague, a pandemic and the evacuation due to fire, or the pandemic and other serious illnesses. Do you have any comments for Sharon?
This is Doug. We call that complex trauma, and it's difficult to know the trajectory of each individual. In some ways, you could say that reinforcing resilience, almost a fortitude or grit can develop, but we, in experiencing multiple disasters, so we're stronger because of it. There's a concept called post-traumatic growth that's actually occurred, and some research around that. It's something to look up. But to that end, those individuals that are underserved or fragile by way of poverty, health, access are always going to be impacted disproportionately than others. And so to that end, we are always worrying about those who are disenfranchised. And every disaster is different. The signatures are different. And to that end, we always look for those who are the most fragile.
Thank you, Doug. Go ahead.
And if I can speak at a community level, we've certainly seen communities in Alberta, and I think Michelle alluded to this earlier, that Fort McMurray, for example, has experienced a series of disasters. And I think at a community level, how we work with them is really in that respectful space. What is it that they need? And what is it that they are ready for at this time? Because it might not be the same for each community. And working with people and communities to develop sort of their blueprint.
Wonderful, thank you. Anyone else with comments from the panelists? Hearing none. Go on to the next question. Given the extensive nature of this pandemic or trauma, I wonder if more people would feel relief rather than latent anxiety and depression. Any comments from our speakers? Oh, sorry. No, that's it. Any comment or response from our speakers? None.
It's Michelle. I just think that's I hadn't considered that perspective, and so I appreciate that optimism, and perhaps I need to adopt that. Thank you.
That's fair.
Paula, it's Naomi.
Oh, go ahead.
I echo Michelle's comments around it's an important perspective, and I think it also speaks back to the graph that Diane showed about the ebb and flow of emotions and experiences that individuals have post-disaster. And certainly there is, I believe it's called the heroic honeymoon, or that honeymoon phase that does happen that is correlated with relief. And there is extensive research about the supports required in those periods of relief, knowing that as a pandemic continues or a disaster continues, that equally people may fall back into anxiety. And so I do think there is, it's important to recognize that individuals will be at those different stages at different times as well.
Yeah, that's good advice. The cyclical nature of this, it's not, a progression in a linear fashion through a variety of emotions, but that one can, as you mentioned, ebb and flow. This next question is for Michelle and Diane. Why was expanding family violence services for Indigenous, rural and remote, and suburban communities identified for targeted population? What did we see that was different for these groups in comparison to the urban and general public?
Absolutely. So it's Michelle Craig here. I think that it really ties back to one of the principles that I think almost all of us touched on, is the concept of individuals with other vulnerabilities or facing additional barriers during and in time of a pandemic or any other disaster for that matter, really their level of need, and it's even harder for them to get the things that they need. So in rural, remote communities and Indigenous populations, it was already difficult to access these services. We know that family violence increases markedly during disaster cycles, and we've definitely seen with the pandemic, particularly as people were isolated at home, we definitely saw increases in family violence and sexual violence, and so that's why that was specifically targeted, is to try and increase access to services to a population that we suspect is going to see an increase in issues where they already had difficulty accessing these services, so to try and reduce some of those barriers. Diane, did you want to add anything to that?
No, I think you've covered it. Thank you.
Thank you. This Zena is asking if there will be any webinars. Do we search up HeartMath to take these workshops as an AHS employee? So folks from Alberta Health Services, how do they access?
Oh, that's wonderful. Yes. These are posted on our website, on the external website. It's the Help in Tough Times. If you just type that into the box, and if you don't find it, just email me.
Wonderful. Thank you. Let's see. Wondering if there will be webinars like this that present or speak to what has occurred and is occurring in other provinces. So it's a great question. We're really interested in hearing from participants here about what's happening in your province, and perhaps we can revisit the webinar idea to find out what's going on elsewhere. If you have knowledge of that, let us know, and maybe we can put some a resource together that highlights some of that. Let's see, are those resources available to those not from Alberta, and how might they access the information?
If I can start with that response, this is Diane speaking. So, you know, the services are funded for Alberta, and this becomes, I think, sometimes a bit of a challenge. Although, having said that, you can sign up, you know, for the for the webinars or the training if you're from out of province. So you can do that. It's just we don't advertise it because we really won't be able to keep up with the demand.
Fair.
It's Michelle Craig, and if I can just add a note on that too, it will depend what resources you're looking for, obviously. However, there are some national resources. The Wellness Together platform from Health Canada is one that I would suggest people look at. It's very comprehensive. It is more support-oriented as opposed to educational-oriented, but it would certainly be one that's available to all Canadians.
Oh, that's very helpful. Thank you. And let's see if there are other questions here. Have you seen an impact? Oh, it just popped away from me. 1 second now. Have you seen an impact on patient population being admitted for mental health challenges related to the impact of COVID?
This is Doug. I'll take that one. I serve Mercy down here in outpatient mental health, and we have psychiatry, psychology, and social work across 3 clinics. Know that Louisiana, and you probably watched us in the news, followed us, we're a hot spot considered in the U.S. With COVID. So I think it's a good measure of the pulse of mental health overall. We serve both rural and urban areas. In my experience, what I'm seeing coming through our intakes is that anxiety and depression rule the day. Our third referring question is around attention deficit disorder, primarily in youth into college age. My point here is that these are pre-existing conditions. These individuals have been suffering these conditions for over 6 months, either previously diagnosed or at least identified by way of symptoms. When I look at the intakes, I also look at them referencing COVID-19 or the coronavirus. Only 5%, and now of about 300 individuals since February, only 5% have identified COVID-19 as the direct referring problem. So that being said, it refers back to individuals being fragile and finding those who have pre-existing conditions that make them a little more vulnerable. And so to that end, research in Time magazine, I think last week, came out with some original research around children and looking at mental health conditions. Again, I think like we've seen after large other disasters, those individuals needing the most help first are those with pre-existing conditions. But depending on how far we go with this, we may have direct referrals easily understood as being directly connected to COVID-19.
Thank you, Douglas.
If I can make a comment as well, this is Diane. What we're seeing here in Alberta is because of the measures that needed to be taken due to COVID, initially people stayed home. They didn't go to emergency departments, and so that, whereas they probably needed to. And so what we're seeing now is increases in those presentations and people who've delayed seeking help for their needs, and so that's creating the demand now.
Michelle, Craig, and I'll just add to that. What we have seen is an increase in alcohol sales. I believe it's something in the order of 20% across the country. So fairly significant increase in daily intake of alcohol, and in Canada, cannabis, because it's legal here. And we suspect there's an increase, or certainly there's a shift in patterns of ingestion of illicit substances as well. And we're seeing some of the impacts of that. Early numbers from some of our monitoring in terms of our emergency service responses, etc. I think the other thing I will mention is that we know this is an area of surveillance, and just today I received an email from my provincial territorial colleagues, and Health Canada is doing sort of a little survey across the provinces to asking exactly this question. So stay tuned, more information is coming.
Good to know. Thank you. The last question we have received so far is, has there been, well, actually we have two. Has there been an application or consideration of how different cultures would respond with a psychosocial lens? For example, are there principles and domains for support the same within Indigenous communities or newcomer communities, for example?
This is Naomi. I'll start, but Doug, do you want to jump in first?
No, you go ahead.
So I was going to start with saying Doug will probably be able to answer this one better than I can. But from my understanding within PolicyWise, we have done evaluations within Alberta of the psychosocial response following the floods and Fort McMurray fires. And through that evaluation, we did have primary data collection with our First Nation communities and those newcomers. And some of our findings with that work were the principles remained the same. However, the application of those principles did differ between the community groups. And that's where understanding the community context and the importance of having a community-based response is fundamental. There is not a one-size-fits-all when it comes to providing those psychosocial supports. And those community voices need to be a part around understanding the types of supports that will enhance the psychosocial well-being. But in essence, the principles did apply across those diverse populations. But Doug, I'm sure you can add more to that.
Thanks, Naomi. And beyond Fort Mac and Wood Buffalo, we can also consider internationally the impact of programs like Skills for Psychological Recovery. It comes down to the nuances around we and they and I. And so how does a community consider itself as individuals or more a sense of community? So say in Japan, where we rolled out SPR after the Fukushima nuclear disaster, tsunami, there's more of a sense of we and less of I. So things like, say, How's Your Five or aspects of, say, Skills for Psychological Recovery may not land exactly as we would expect if we were rolling it out in Alberta or Ontario, Nova Scotia. And so to that end, it's the art of disaster response is absolutely fascinating, and I think we can all agree that it's not only a challenge, but it's why we get up in the morning. It's also what keeps us awake at night and finding the right way. I believe that although you can bring in expertise from the outside, like the presenters on this call, every response to a disaster, man-made, natural, has to be local. And so that combined expertise is so important. And so I'll leave you with that. I know that we just have a few more minutes.
Thank you.
It's Diane. I just wanted to add on those great comments that in keeping with those principles, what we've been able to do is, for example, work with our Indigenous communities and create a psychological first aid version of that training for Indigenous communities and delivered by Indigenous communities. So that's just one example. Thanks.
Thank you. Last question, and that's how has buy-in been for the psychosocial intervention or response? Has there been work required to convince or explain its importance?
This is Michelle Craig, and I guess it depends on your audience. Certainly from a community response, given the response that we've had to the community grant program, I would say that it's a fairly robust response, and that there is buy-in, and that may be in part because we're offering grants, but there's certainly been definitely a recognition of need and a desire to have supports and address needs in people's communities. In terms of political and government responses, both provincial and federal, obviously with the resources that have been announced and across the globe internationally, clearly there has been some very significant commitments and obviously an understanding of the impacts of the pandemic from that perspective as well. So I would say on the whole, yes, I believe there is. There's always education required because for some people this will be brand new information. A year ago, how many people knew about PPE? Now everybody knows about it, as an example. But from my experience, I would suggest that has been buy-in.
Wonderful. Thank you. Well, thank you, Naomi, Douglas, Michelle, and Diane. Thank you to all of our attendees for spending this time with us, and we hope you depart with some practical improvement ideas. On October, I'm moving ahead. On August 19th at 11 a.m. Eastern, we're pleased to bring you the third in a three-part webinar series related to neurodevelopmental disorders. At that time, we'll discuss case presentations during which our speakers will respond to the cases you've shared in advance with them and bring some of their own. Don't forget, you can stay up to date on all of our activities and events by signing up for our Children's Healthcare Canada Spark newsletter and following us on Twitter at Child Health Can if you have not already done so. It's always great if you watch live, as your questions and comments really enrich the discussion, but if you can't, the recordings of these sessions are made available after the fact on our Knowledge Exchange Network. So thanks again for joining us today. Thanks to Alberta Health Services, PolicyWise, and for Douglas from Mercy for supporting our webinar program, and hopefully we'll see many of you back here next week. Bye, everyone.